A very good day, my dear postgraduate students. I welcome you to the discussion on the gross pathology of the kidney, part 2. This shall be limited to non-neoplastic lesions. This is a recapitulation of our previous session. This is the kidney, a loop of the colon, and these are the fascia around. What we will have to concentrate will be these are the folds of the peritoneum. This is a kidney as such, which has got a capsule. And then there is a perinephric fat. This in turn is being surrounded by the R.A.T.S fascia. The red colored one is the R.A.T.S fascia. And external to this is the paranephric fat. Courtesy allow me for this beautiful line diagram, which you people can have in mind. And this incidentally is Gerota, under whose name the fascia still stands. Whenever we talk about the abnormalities, it can be congenital anomalies as well. Here again, it is a quick recapitulation. What are we seeing on the screen? Here, the kidney is in the pelvis. So it is an aberrant kidney or a pelvic kidney. Sometimes there can be a communication between the lower loops of the kidneys leading to a horseshoe kidney. Also, developmentally, I can see both the kidneys on one side, or there can be multiple blood vessels. In this case, the aberrant renal arteries can be a cause for the renal hypertension. This is a rosette-like kidney or a cake kidney. And as I had mentioned earlier, the aberrant blood vessel can also kink onto the ureter, leading to a hydroureter or a dilatation of the renal pelvis and hydronephrosis. Coming to the development as such, there are a few important components of the kidney. One will be the ureteric bud and then the pelvic ileal system. Second one will be the stroma. Third one will be the parenchyma. And fourth, the blood vessels. In this case, there is an induction in the sense it goes into the renal parenchyma or the condensed mesenchyme. And it branches leading on to the calyces. Here I find there is a widely developed pelvic ileal system with the primary and later on the secondary branches, around which is a condensed stroma, and the green colored one will be the parenchyma. These again are not completely developed. See what is happening over here. There is a glomerulus and then there is a tubule that is developing along with it, and it differentiates into the ducts of varying stages. Ultimately, you get a complete unit of the kidney called the nephron. This we will be having in mind for our help thanks to ResearchGate. Coming to the normal anatomy, always abnormal should be differentiated from the normal. The normal weight is about 150 grams, 10 grams on either side. Measurements being 10 into 5 into 2.5. Easy to remember, one is half of the other. There is a corticomedullary differentiation. There is a brown and then a darker brown over here. And there are the renal pyramids. All these are the renal pyramids. Minimum 8 to 10 will have to be seen on the cut surface. There are areas in between called the renal columns. The capsule usually is strippable and it is transparent. I'll be able to see the underlying renal parenchyma. And the pelvic ileal system is intact. Here I can hardly see any dilatation. The yellowish color denotes the pelvic fat, and this area is the renal sinus. So this is a normal anatomy which we should have in mind. When we talk about the non-neoplastic pathology, these are the terms that we should have in mind. Congenital hypertension, amyloidosis, contracted, hydronephrosis, pyelonephritis, calculi, end stage, polycystic, rejection, and so on. That is why it is said, when you go in search of honey, you must expect to be stung by bees. There is too much of a terminology and we may falter, but then it is not wrong at all. The congenital anomalies you people are seeing, again, rapidly I am recapitulating so as to maintain the continuity. A horseshoe kidney, remember the lower poles are being communicated and this is the aorta and the inferior vena cava. Sometimes there can be dual ureters or there can be a single ureter on one side and double on another side. Also, there can be conditions such as aplasia, hypoplasia, ectopic we have already seen, and cystic dilatation is not uncommon and it does not affect the function of the kidney. This, of course, is the bladder that we are seeing. There are certain important things that we will have to do, whether it is going to be a neoplastic or a non-neoplastic lesion. So let us assume it is non-neoplastic. There are a few triage that you will have to go through. One is weigh and measure. This we usually miss. And when I say measurement, it has to be a three-dimensional measure. And weight is indispensable. Measure the length and the diameter of the ureter and the other structures such as the blood vessels. In case you suspect a mass, that particular region will have to be externally inked after palpation and monitoring it. The outer surface of the kidney adjacent to the mass will have to be inked. And you take a circumferential emphasis of the margins and also the distal ureter, renal artery and the renal veins. These structures will have to be very clearly demarcated. See this beautiful line. The ureter is open longitudinally. Usually we give a cut surface of the ureter. But if you do suspect any kind of an abnormality, it is not wrong to have a longitudinal cut, particularly a transitional cell carcinoma within a ureter. Bisect the kidney from the perinephric pad to the renal hilum. The accessory renal artery, as you are seeing in this condition, can be a source of hypertension. And what we should remember will be that these radiographic images are a great lending hand to the pathologist. Apart from that, we'll have to identify the adrenal and maintain the cut surface, measure it, the corticomedullary differentiation, and the thickness. The kidney is supposed to be sliced at an interval of 1 centimeter. This is a little too much for our thing, but I would suggest at least bisect each half longitudinally, and then it has to be fixed by means of a filter paper, which is again being immersed in formalin. Examine the kidney for any cyst or any of the masses, and then these will have to be measured in the 3 dimensions. Overnight fixation is preferable even if it is an emergency case. There are some conditions such as renal hypoplasia, dysplasia, and aplasia because of abnormal development. This affects about 2 to 4% of the population. Look at this one. The kidney on this side is normal, whereas here it is hypoplastic. As a continuation of the grossing, we will have to look for the consistency, the subcapsular surface, whether there is any exudate or thickening of the capsule adhesion that is present. And you will have to submit representative areas from the cortex, the medulla, the pelvis, and also the thickened areas of the capsule. If masses are identified, then you will have to give the inking and then the appropriate margin along with the normal tissue. These are well dealt with in neoplastic nephrectomy. This diagram is just for a recollection of the cortex, medulla, the pelvic ileal system, and the renal artery and renal vein. Now, in this condition, what are we seeing? The shock kidney diagnosis is there. But if you do get such a specimen, what are you going to explain? Or what do you see? Here I find that in the cortex, there is a definite pallor. Shock, all of us know there is going to be a diminished perfusion of blood, hypoperfusion, as a result of which obviously it becomes anemic and hence the pallor. Also, this pallor is extending into the interpyramidal regions, whereas the pyramids and the medulla are being well preserved and show a different contrast when compared with the cortex. This is typical of the shock kidney, which is due to the hypoperfusion. This by itself is a question for us. There are too many conditions leading to acute tubular necrosis. We can read up. Thanks to the reference. Another condition which we shall always remember will be the flea-bitten kidney. Look at this kidney over here. The capsule is stretched, shiny, but then I am able to find multiple pinpoint petechial hemorrhages in the subcapsular region, in the cortex. And this can be because of any of the vascular malformations or because of immunological reactions or because of infections. So, malignant hypertension, infective endocarditis, henoch-Schönlein purpura, which is a vasculitis, polyarthritis, again an immunological disorder, TTP, rapidly progressive glomerulonephritis. These are certain conditions wherein you can have this flea-bitten kidney. Kindly have a compilation of this and repeatedly read them. It will pay rich dividend in your exams. The granular contracted kidney is another entity. The kidney is usually contracted as a result of fibrosis. In this case, I am finding a pair of kidneys which are bilateral, more or less symmetrical, contracted, and externally there are fine granules that could be made of a granular contracted. So, obviously, there is a reduction in the weight, fine granules, uniform, bilateral and symmetrical can occur in some conditions which are immunological. For example, nephrosclerosis or a chronic glomerulonephritis. Mostly glomeruli are all immunological disorders. And so, both the kidneys are being equally affected by means of the antigen-antibody reactions. Renal artery stenosis, again, it can be unilateral or bilateral. Pyelonephritis, on the contrary, there will be a contraction of both the kidneys, or it can be restricted to one kidney alone. And you find that the scars will be coarse. And if at all both are going to be affected, it is going to be asymmetrical, we shall be seeing. Again, a granular contracted kidney in a case of a hypertension, benign nephrosclerosis. You find that it is fibrous, contracted, and microscopically you can see these things. There can be a hyaline arteriolosclerosis, atrophy of the tubules, interstitial fibrosis, and glomerulosclerosis or fibrosis. This is what we had seen. In some conditions, amyloidosis, early you find that it is enlarged in size, but later on there is fibrosis and a contraction. So the entire list you people should be quite fluent with it. Tubulointerstitial disease. We have seen some glomeruli, we have seen the congenital disease, etc. But then tubulointerstitial is another entity. In this case, what happens is the kidney is usually about 10 to 11 centimeters long. It is reduced in length as well as in weight. Obviously, there is going to be a dysfunction. It is going towards an end stage kidney. And what I am seeing here is the interstitium. There can be a few trapped tubules here and there, but predominantly it is fibrous tissue along with inflammation, which means there is a corresponding decrease in the renal parenchyma. Amyloidosis of the kidney. Amyloidosis classically, these chapters I would like you people to read your Robbins repeatedly so that you get the go of it, the feel of it. You find in amyloidosis, the kidney will be enlarged. For that matter, any organ, it will be pale, waxy, glistening, smooth. But in the later stages, there will be a fibrosis and there can be a contraction. And this, incidentally, I purposely, though it is out of context in this case, let us recollect the stains for amyloid. Under HNE, you find it as pink hyaline, homogeneous. Methyl violet and crystal violet, these are metachromatic stains. Congo red is again under polarizing microscope pink, and it is giving an apple green birefringence under a polarizing microscope. Thioflavin T, thioflavin yes. So there is a fluorescence, and immunohistochemistry can be positive against the febrile protein. Grossly, it can be demonstrated by means of sulfuric acid and iodine. Look at this kidney. I thought it was almost normal. There is some kind of a distension, but then there is something wrong here also. The renal parenchyma is quite thick. It is not getting distended as it should be. So it is not a pure case of a hydronephrosis. And externally again, there is too much of the scarring and puckering that is seen. So it is a case of an end-stage kidney, and this can be measured by the subsequent slide, which can be because of glomerulonephritis, hypertensive nephrosclerosis, diabetes, IgA nephropathy, polycystic kidneys, chronic pyelonephritis, and so on. The list will go on. The end-stage kidney is basically based on the function rather than the size. So when the nephrologist or the urologist sends us a specimen, we are quite shocked because it looks almost normal. But then these are the various stages, stage 1 to stage 5. You find that the glomerular filtration rate is more than 90 ml. It progressively decreases to 15 ml per minute. And there is a renal failure towards it. This grading you people should know. The differential diagnosis for this end-stage kidney, there is an elaborate list. Almost any of the disease, when it is persistent, can lead to a renal failure. But the bold letters, let us try to memorize. Glomerulonephritis, pyelonephritis, RPGN, nephrosclerosis, hypertension, diabetes, etc. Though polycystic kidney, amyloidosis, gout, SLE, etc., all can lead to a renal failure. So this slide is from San Diego School of Medicine. It is a case of a contracted kidney, as I had mentioned here. Strangely, I am finding a scar at the poles of the kidney, and there is a blunting of the corresponding calyx. This I would not say there is too much, but then there is an early dilatation of the pelvic ileal system. I would like you people to kindly appreciate the difference between these two. In one, this is almost this, and it is a case of a reflex uropathy or reflex nephritis. So whenever there is a bladder contraction, part of the urine goes into the kidney and it goes towards the pole, leading to a polar fibrosis, and hence you get this kind of a pattern. On the contrary, whenever there is going to be an obstruction because of a tumor, intrinsic or an external obstruction or a calculus, you find that there is a backflow and it affects all the pelvic ileal system uniformly, and hence you find that the scarring is there throughout the kidney. So two patterns we shall be remembering. And this is a beautiful one from web pathology called as necrotizing papillaritis or chronic papillary necrosis in a case of diabetes mellitus. But then many can be seen. Look at these renal pyramids. You find that the pale area is the area of necrosis, whereas this is a viable area. Normally, it is supposed to be affecting 2/3 of the pyramids. A lot of conditions are there, postcards. But first and foremost, let us remember necrotizing papillaritis for diabetes mellitus. And postcard means there's a mnemonic I would like you people to kindly memorize. Pyelonephritis, obstructive disease, sickle cell disease, tuberculosis, liver disease, analgesics or alcohol, transplant rejection, as well as systemic vasculitis. So this is a beautiful mnemonic, kindly memorize. So this is actually a variant of pyelonephritis. Now, this is a slide of pyonephrosis and tuberculous pyelonephritis. Pyonephrosis is where the kidney is converted into a bag of pus. Chronic pyelonephritis, particularly in the case of tuberculosis, has a different. And in any case of this pyelonephritis, you find that there will be the ragged inner surface, as can be pointed out by this. It is not smooth, and there can be some amount of hemorrhage and congestion because of the inflammation. You find this is another one. There is the areas of GC or caseous necrosis, yellowish white, that are seen typical of the tuberculous pyelonephritis. This again is a case of tuberculous nephritis. Thanks to WebPath for this beautiful picture of it. I find that the pelvic ileal system is being distorted, and then there is the friable areas of caseous necrosis. And sometimes there can be mottling, and on dystrophic calcification, it can become radio opaque. So in this case, I find that there is a distension of the pelvic ileal system. The pelvis over here, calyces, and it is being distended to such an extent. Actually, in PhD Medical College in Coimbatore, there is one specimen which is more than a foot tall, and it is nothing but a inflated balloon of the kidney. There will be hardly any parenchyma. If you go near the specimen, it will burst. And here, compare it, I find that the inner surface is smooth and glistening. Hydronephrosis will be the typical one for this. Whereas when it becomes inflamed, it is called as pyelonephritis. Look at this one. This is a case of a hydronephrosis. There is a distension, thinning, and also there is an atrophy of the renal parenchyma. There is a distension of the pelvic ileal system. Here also it is happening, but it is ragged over here. And again, I'm able to see some calculi that can be a cause for the obstruction in this case. I would like you people to kindly compare. The hydronephrosis again, just like pyelonephritis, it can be unilateral, it can be bilateral. Unilateral in the sense when there is obstruction only on one side. Calculi, obstruction of the pelvic-ureteric junction, aberrant blood vessel, ureteric tumor within one ureter, retrocaval ureter, and extramural compression in a tumor, lymph node, sometimes in pregnancy, granuloma, cyst. These are all some of the causes for unilateral hydronephrosis. This entire list I would like you people to kindly buy. Be very fluent with it. And this is typically our friend, the staghorn calculus. So it is a cast of the pelvic ileal system. Bilateral hydronephrosis, on the contrary, when the obstruction is going to be lower down, bladder outlet, or in a case of phimosis, benign prostatic hyperplasia, posterior urethral valve, urethral stricture, sphincter dyssynergia, or there can be ureteric obstruction at the point of entry into the bladder, cancer of the external structures, or a rectal cancer, neuropathic bladder, where the bladder is dysfunctional and there is a back pressure. Sometimes radiotherapy can lead to scarring. And there is an entire other list. I would like you people to kindly go through the entire one. Not only the renal disease, appendicitis, diverticulitis, periarthritis, and radiation, all these things can lead to a hydronephrosis. And look at this. There are different ways of grading it. Mostly it is a property of the radiologist. There is a SFU grading system and the one-ends alternate grading. Whatever it is in one, I am finding it is confined only to the pelvis, and then it is extending into the calyx, and then into the secondary calyxes. And finally, the entire lot is becoming distended with a thin rim of parenchyma. That is how you people stage it. I would like you people to kindly describe these two pictures. Take your time. What are the abnormalities that you are seeing in this? In one, the kidney is almost atrophic, so you can call it a dysfunctional or a non-functional kidney and they have done an effect. Along with that, there is something wrong with the ureter also. It is thickened. So there is a megaureter, hydroureter, as well as an atrophy of the kidney. And probably there is some calyx that I can make out here. Kindly look for it in all the specimens you are supposed to decipher something. Here again there is a distension and it is probably the branching calculus that is seen, a staghorn calculus. So I am able to find it in multiple calyces as such, thanks to pure digital. Renal stones. This can be a question or when you get a specimen or a case, obviously you are going to answer. I would like you to recollect only this last column. Calcium oxalate, calcium phosphate, uric acid, struvite and cysteine. So these are the things which is radio opaque and which is radiolucent. All the properties you people can read up given well in your other text as such. The renal stones can be the calcium stones, uric acid stones, struvite or the magnesium, ammonium phosphate, cysteine stones, etc. And this is a beautiful line diagram of the same. I would like you people to kindly have it in mind so that even when you get a urine examination, you are supposed to be thorough with the microscopic examination. And what are all the radiological methods of diagnosing this? Mostly you find that it is diagnosed by means of the radiologist and the urologist and they go in for a lithotripsy. The pathologist is the pathetic last. So that can be the procedure. Kidney, ureter and bladder visualization by ultrasound, intravenous pyelogram, and there can be a CT scan, etc. There can be a plain radiograph as is mentioned over here. Acute and chronic pyelonephritis. Acute pyelonephritis in the sense there will be areas of inflammation, there can be abscess formation which is seen. I would like you to kindly differentiate it from the multiple petechial hemorrhages we have seen in a case of a flea-bitten kidney. In this case, it is more of an inflammation and an abscess, particularly in any case of acute inflammation. In chronic inflammation, chronic means always there is a scar. Look at the coarse scars. The capsule will be adherent. And when you try to peel it off, you find part of the parenchyma will also come along with it. The scars are coarse. They are asymmetrical, addition of the capsule. One other set of lesions will be the cystic diseases. In this one, I'm finding that they are all radial. Externally, it is looking almost normal. So it is a case of an infantile polycystic kidney. The external surface, I am not able to find out any lobulation. On the contrary, look at the external or the internal, I am able to find multiple lobules. As in the case of cirrhosis, only thing these are all cystic spaces filled with urine. It is a case of an adult polycystic kidney. So again, an adult polycystic kidney that has been cut through, and you find that there are the cystic spaces of varying caliber that are being uniformly lined. And there's a normal kidney that is being given for comparison. And what is the basic pathology of the cystic lesions? There will be the tubule. These are all formed from within the tubules. So there can be a compliance of the tubular wall. So it becomes weaker, it gets ballooned out. That is one. Two, there can be a hyperplasia. It applies more of pressure. Again, there can be a balloon. Third one, there can be an obstruction as a result of which there is a distension. And fourth one, you find that there can be a kind of mitotic activity that goes on as a result of which again there is a developmental abnormality resulting in a cyst. So these are certain things that you'll have to remember. You can go back to my class on polycystic diseases of the kidney. So again, a beautiful one. I finding radial cystic structures hardly they seem to be coming out of the kidney. The external surface is almost normal, but for some bosselated appearance. Thanks to step codes. The eyes are useless when the mind is blind. So we are seeing many a thing, but then ultimately we are not able to decipher what it is. That is because we have not read it up. I would like you people to repeatedly reinforce. Repetition is the mother of knowledge. The cystic diseases, these are all the various things. They can be heritable, they can be non-heritable. Kindly Why had the entire list as such? Medullary cystic disease, etc. It need not be always adult and infantile. And sometimes it can be a tumor with a cystic degeneration. There can be parasites such as hydatid, or there can be a simple cyst, as in this case. It can be associated with dialysis. So the staghorn is just staring at us. Thank you for your wonderful attention. I would like you people to kindly master this non-neoplastic lesions of the kidney. Thank you once again.